This group has two subtypes. This I have taken from USMLE textbooks. Crohn's disease and ulcerative colitis. Sometimes different. Calm down. Lab coats if you have taken. Anyway, it is going to rain, so it's not very hot. Initially, it was called. I promise I'll not keep you too long. As soon as we finish, you may go. But if each 10 minutes I'll tell you some notifications, we'll never finish. So you'll go later. Choose. Ulcerative colitis, when I was a student, we passed up to 9 Russian literature in Armenia. Sometimes it's used to be called, non-specific ulcerative colitis. Nowadays we are just telling ulcerative colitis. So ulcerative colitis, UC and CD, Crohn's disease, together are forming inflammatory bowel disease. They share a lot of similarities. And just going forward, in up to 10% of cases, you may not finally subdiagnose, differentially diagnose who is who. And you just treat as inflammatory bowel disease. Even while after using all toolkits you have, biopsy, endoscopy with biopsy, biomarkers, and so on. Crohn's disease. At first, when it was described by Crohn and colleagues, it was called terminal ileitis. So it's terminal portion of the ileum when it's becoming sicker. And where is it? It is in right lower quadrant. Where is the also appendix?
Yes.
So a lot of people, even up to now, may be misdiagnosed with acute appendicitis and may undergo surgery.
Yes.
Then after the surgery, it is again recurring, which is impossible in case of appendicitis. So these are disorders of unknown origin. Even some authors, you may add this, they are considered as small vessel vasculitis. Very small vessel, non-ANCA associated, anti-neutrophilic cytoplasmic antibodies, not non-associated vasculitis. Because small vessel vasculitis, part of them is ANCA associated, part of them is not. These are non-ANCA associated usually. One of them is associated mostly. One of them is not associated. Now I'll show you. Look. They can be discussed simultaneously because of a large degree of overlap in terms of presentation, testing, and treatment. But from the start, let's understand. So Crohn's disease may affect any part, theoretically, of GI tract, from oral cavity up to the anus. Usually rectal part is sparing. It's called rectal sparing. Rectum is not involved. Usually. Ulcerative colitis starts from the most distal part and is spread to proximally. Maybe limited to this, maybe I'll show you, maybe the whole. So we may have left-sided disease, we may have pancolitis. So mostly affects large intestine. But in 1% of cases, it may affect ileum. It's called backwash ileitis. But it's rare. As you understand, main problems may occur in if diagnostics is Crohn's disease or ulcerative colitis if we have affection of large intestine. Because if it's stomach, you'll never think about ulcerative colitis. Also, in ulcerative colitis, usually we have superficial inflammation, mucosa, submucosa. Meanwhile, for Crohn's disease, it's transmural. That's why for Crohn's disease are more typical fistula formation. Though, from another hand, in ulcerative colitis, we may have deep lesions which may involve other layers. We may have abscess formation. It's also possible. So, and these disorders have very high incidence. And if you remember in general part when we were speaking, we told that family history usually doesn't play a role besides this case, IBD. If patient has IBD, so first degree relatives, likelihood of other generations is also very high. It is very typical for Jews. That's why a lot of institutions are in Israel, which are studying these disorders. It's very common there. There are two types of Jews, like two groups ethnically different. Both are Jews. One is called Sephardic Jews. Second is called Ashkenazi Jews. Ashkenazi Jews are 3 to 5 times at higher risk of inflammatory bowel disease. So it's linked genetically. So idiopathic disorders of the bowel associated with diarrhea, bleeding, bloody diarrhea we may have, weight loss, fever, and abdominal pain. Most accurately diagnosed with endoscopy. And then biopsy, strict sign of small bowel follow-through after daily meal in Crohn's disease. I'll show you. And medications, anti-inflammatory medications. This group is called 5-ASA derivatives. Aminosalicylic acid derivatives, sulfasalazine, mesalazine, and so on. We'll speak. Azathioprine and bricaptopurine are cytostatics. Are not used only for this, but are used. And glucocorticoids usually are used for acute exacerbations. This is just by the way. Now, comparison. Crohn's disease, not ulcerative colitis. In Crohn's disease, we have linear, star-like, stellate deep ulcerations with skip lesions. I forgot to tell skip lesions. Skip lesions means
Patches.
just show you. I understand that it's not continuous, I want to show. Look, ulcerative colitis starts either proctitis or proctosigmoiditis, maybe left-sided disease, maybe the whole intestine, it is being spread more proximally. Here we don't have skip lesions, it's continuous lesion. Meanwhile, for Crohn's disease, look, iliocecal part, small intestine, colitis, rectal sparing. And also sometimes we have perianal disease. We have fistulas in perianal region, and it may be misdiagnosed as paraproctitis, but in reality maybe Crohn's disease. Now, Crohn's disease, we have linear stellate deep ulcerations with skip lesions, which may involve entire GI tract. In ulcerative colitis, we have mucosal edema. It is endoscopical pathological findings. Erythema friability, but ulcerations, ulcerative colitis. Here we have transmural involvement and granuloma formation. And ulcerative colitis very commonly is manifested by bloody diarrhea, diarrhea prominent, hematochezia also maybe, fresh blood if you look, not melena, but very often bloody diarrhea. Urgency. Urgency, tenesmus and urgency, from some point they are synonyms. Tenesmus is a medical term which is used that patient is going to the washroom for the defecation, but it's like false alarm. Just this, it's very typical for infective diarrheas and so on. It's just sensation due to inflammation. Maybe no defecation messes. In ulcerative colitis, very often we have crypt architecture is impaired, shortened branched crypts and crypt abscesses. A bit later I'll show you. For Crohn's disease, abdominal pain is prominent and inflammatory masses. In typical featuring terminal ileum, you may palpate conglomerate, like a fusion cluster, of these masses. Inflamed bowel is being palpable in right lower quadrant or right iliac fossa, which may you may misdiagnose as appendicitis. Of course, complicated appendicitis. Very paradoxically, smoking is a risk factor for Crohn's disease, and for ulcerative colitis, look what is written. Smoking is elevating. Just a minute. Da.
मोबाइल पर भाव ज़्यादा छोटा है.
So it is taken from observational studies. While studying these patients, they have seen that smokers are less likely to have ulcerative colitis, not opposite. Now, okay, even if like this, it means that to smoke, not to have ulcerative colitis, but die of, for example, coronary artery disease, is also a choice now. Rectal sparing. Meanwhile, rectum is always involved, I showed you. 3 variants we have, yes? Distal disease, left-sided, and pancolitis. In all conditions, it starts from rectum. Cobblestone appearance, these normal defective areas. Cobblestones, you know, yes?
Yes.
Like this, but larger in the streets. Here it is limited to, of course it's not comparing like cobblestone, it is limited to large bowel, just is giving peculiarities. Strictures and fistulas are very typical for Crohn's disease. While streak sign is a variant of stricture. No skip lesions, anal involvement or fistulas, less likely. Fistulas in case of ulcerative colitis. The complications include diarrhea, calcium oxalate kidney stones, and cholesterol gallstones because their metabolism also may be impaired on the background of this inflammation. About associations, look. Ulcerative colitis is associated with ANCA, anti-neutrophilic cytoplasmatic antibodies. Meanwhile, Crohn's disease, there are found anti-Saccharomyces cerevisiae antibodies in this case. And look what is telling. This is just for US assembly. They are trying to be mnemonic, okay, for you to memorize. If a patient is ANCA positive and ANCA negative, has a 90% chance of having Crohn's disease. Opposite negative and positive, is having ulcerative colitis. But both ANC associations and non-associations, they are for small vessel vasculitis. So from some point of view, they are also considered as variant of vasculitis. On rheumatology part, we don't have, yes, we do. Okay. Look. Kidney stones are more often seen because the fact that malabsorption causes reduced calcium and increased absorption of oxalate. So metabolism is happening. Sometimes it's used cholestyramine. Cholestyramine is a binder. Is binding this calcium oxalate, this stone formation. Okay. Sometimes it's used. In Crohn's disease, prothrombin time may be prolonged because of vitamin K malabsorption, which means that we may have increased risk for bleeding. Prothrombin time. Therapy for is not needed. You will have active maintenance therapy, like basis therapy and active therapy for exacerbations. So once more, look, proctitis or proctosigmoiditis, rectum, left-sided extensive disease, and pancolitis. Skip lesions. Ulcerative colitis, look, is limited to colon once more. We have diffuse mucosal inflammation, and we may tell this is which variant. Pancolitis, distal, extensive, so on. Pyoderma gangrenosum, look. In ulcerative colitis, very often, though in Crohn's disease as well, we have extra colonic manifestations out of the intestine. Extraintestinal. Because these are autoimmune disorders, we have autoantibodies against various sites, including skin. And we have pyoderma, gangrenous or gangrene-like pus, purulent inflammation. Which may be during your check-up, during your visual inspection, general inspection, you may get this. This is endoscopic view. From the left is normal, and on the right, like it is ulcerative colitis, you see, inflamed area. In Crohn's disease, it is patchy transmural strictures, look. Maybe fistulas is not shown, may affect any part of GI tract. But to be honest, only based on this, I will not tell them, but I'm not an endoscopist. It's not the best picture. They've got. Look, normal colon and ulcerative colitis. You see here goblet cells. In this case, they are lacking crypt distortion and crypt abscess. But mostly affects mucosal, submucosal layer. This is normal. This is a microscopic view in case of ulcerative colitis. Which investigations we are doing are listed here. I'm not going to read them, but we should understand why is done each of them. Blood tests. Blood tests, for example, we may do CBC. We may reveal increased ESR. It may be also for the severity. Bacteriological tests always are done, or very often, because we should understand this diarrhea is infective diarrhea. Maybe Campylobacter, Yersinia, Shigella is the cause. Not all diarrheas are due to inflammatory bowel disease. Endoscopy, no need to tell how much it is important. Why we perform endoscopy? First of all, for diagnosis. Second, to understand which part is affected, especially for ulcerative colitis. Why? Especially because upper GI endoscopy is reaching up to duodenum. Other parts we are skipping. There is video capsule registration. When patient is like a pill is swallowing a capsule, it's a video and it is recording while passing through the GI tract. But to tell that this method is too much widely used and very, very informative, no. It's not, and also expensive, but instead of this, very often are used barium studies, nowadays with CT enterography or MRI enterography. We may understand stricture. We may perform biopsy for fine diagnosis. If we have filling defect while wearing solo or enema, we see that is not passing. Filling defect. It's already an indication, if before this was done, for endoscopy. By this we can differentiate between ulcerative colitis and Crohn's disease, and for follow-up. Look, any chronic inflammation predisposes to that site cancer usually. Chronic hepatitis may result in hepatocellular carcinoma, peptic ulcer disease, may become malignant. Colon is not an exception. Ulcerative colitis predisposes to colorectal cancer. And more time is passing from the diagnosing of ulcerative colitis, higher is the likelihood of colorectal cancer. Look, even if patient doesn't have any complaints, nowadays modern guidelines are telling that if even if we don't have any problems, after 8 years should be performed colonoscopy for these patients. Repeated colonoscopy for revealing of positive signs for colorectal cancer. Why 8 years? Because like statistically they've seen that usually after 8 years it happens. You may do after 5 years, but insurance may not cover. This is the problem. For example, here we have patients who annually are undergoing this for each 2 years. Barium studies, I already told you that I will show you, and radionuclide scan, which may accumulate in labeled isotopes in affected areas or around them. This is Crohn's disease, regional or terminal ileitis. This is not clearly cobblestone appearance. Affected or non-affected areas. And this one is endoscopic image of ulcerative colitis, which is left-sided disease in this case. We have confluent, like fuse, superficial ulceration, loss of normal mucosal architecture. Yes. Next. This slide I like very much because it is showing schematically, endoscopically, and histologically main features which happen in IBD. Now look, it is normal fat which is surrounding intestines. In Crohn's disease, we have fat wrapping, become more. We may have fissures, we have thicker walls, and cobblestone appearance. And in ulcerative colitis, surviving mucosa looks like pseudopolyps. And very typical feature, loss for house stress, is becoming smooth, loss of haustration. This is normal pattern, cobblestone appearance, and pseudopolyps, false polyps. You know, they are not polyps. Next. Crohn's disease. Even we have, but not only for mucosal layer, ulceration and exudates. You see this fluid on the mucosal layer. X-ray. Crohn's disease, regional ileitis, look especially this part. You see, narrow. It means that contrast is not passing normally. Barium solo, which is typical site. Ileocecal this region, regional ileitis. More or less diameter should be the same, yes, of the lumen, for the lumen. Now we obviously see this narrowing. Ulcerative colitis, look, ulcerative colitis, double contrast is a method when you are using barium and air. It is double contrast, it is enhancing. And the barium study shows pseudopolyps for the descending colon. Yes, false polyps formation. From this side. This is string sign, look. This is string sign, you see. The string sign is maybe partially due to the spasm as well. Narrowing caused by incomplete filling as a result of irritability spasm associated with ulceration. So structural and functional problems. String sign. This term often applied to the appearance of any marked narrowing of the lumen, but originated as descriptor of reversible, because that's why I told spasm. Reversible narrowing in Crohn's disease. Characteristic findings, look. We may perform small bowel contrast follow study by contrast barium and CT scan. Now, for this sense, contrast study has advantage, look, because we may see the length of involvement of the areas of strictures, so no need for CT. Characteristic findings, you see abscesses or fistula, string sign. It is in general about imaging. Narrowed lumen mucosal nodularity, ulcers. Ulcerative colitis, look. Here we have very typical finding. It's called late pipe sign, you see, here. This is late pipe sign. it is already due to structural severe changes. Look, appearance of colon due to chronic scarring and retraction and loss of bowel stress. It is leading to this appearance. This is late by side here, or contrast is possible. Barium enema and CT. Now this CT has advantage. These are based on studies. Which one is more sensitive to real CT? Value, contrast, enterography, CT enterography. Findings, what we may find in contrast, CT or value. Value enema may be used in CT enterography. Continuous lesions from rectum proximally with circumferential involvement. This we know. And these repeated episodes of ulcer formation, mucosa, and muscular hypertrophy is leading to shortening, narrowing, and smoothing out of normal austral markings. This is called late bite sign. Is in any tests and so on. I mean, for USMLE, it's written. Radiographic features in Crohn's disease. Look. What we may find? Logical. As also progress deeper, it may lead to fistular formation. Okay. Transmural inflammation leads to decreased luminal diameter and limited distability. Okay, cannot be stand. Radiographic streak sign represents long areas of circumferential inflammation fibrosis, resulting in long segments of luminal narrowing. Segmental nature of CD results in wide gaps of normal or dilated bowel between involved segments. These are skipped lesions. So we may have affected area, normal area, then gain affected area, and so on. But normal areas are completely normal. CT enterography, especially. As far as I told, endoscopy cannot go deeper than duodenum, and colonoscopy cannot come more proximally rather than distal part of ileum like this. This middle part is remaining. That very often are used CT enterography. Large volumes of ingested neutral entering contrast material permit visualization of the entire small bowel and lumen. Unlike routine CT, which is used to detect extra-entering complications, because without contrast we may see just fistulas, abscess. CT enterography clearly depicts, so describes the small bowel inflammation associated with CT by displaying mural hyperenhancement, stratification, and thickening. So it's more sensitive area than without barium contrast. Engorged vasa recta and perienteric inflammatory changes like perianal fistulas and so on. CT enterography is the first line test for the evaluation of suspected CT and complications. MRI. MRI is for pelvic region is superior to contrast to computer tomography for demonstrating pelvic lesions. It's not so rare, I see. Ischial rectal abscesses and perianal fistula. Maybe a cause for the fever of unknown origin until you find that the ischial rectal part has abscess. MRI for children is initial test. And for those people, for those adults who have undergone CT very frequently. MRI enterography is comparable to CT enterography in diagnostic and accuracy. Now let's understand CT, computed tomography, is using X-rays. Is the same X-ray. Three-dimensional is a variant. Then we are like rebuilding this, reconstructing. Just it may give in slices, horizontal and vertical, and then opposite. modern technique allows from this to get three-dimensional image. But normally it is taking 5 slices, each millimeter, 5 millimeters, like this. And of course it's more informative. Meanwhile, MRI is not using X-rays. It is using magnetic resonance effect, so it's harmless for the people. Meanwhile, CT, anyway, it's X-ray and we have radiation exposure. And already from here starts treatment. Details I will not tell. Just I want to show you something here. For both starts clinical coloscopy 8 to 10 years after diagnosis, repeat every 1 to 2 years. Now, why to treat? To suppress inflammatory response and immune reaction. And treatment, aminosalicylates, 5-ASA derivatives, sulfasalazine, and glucocorticoids. Glucocorticoids are used for acute exacerbations. Aminosalicylate may be used both for acute exacerbations and for maintenance therapy. Of course, by the moment you graduate, a lot of new medications and treatment options may be changed, may be suggested. Anti-inflammatory, modern, the exact mode of action is unknown. Now look, these 5-ASAs, besides it, a lot of other effects. Sulfasalazine, classical variant is sulfasalazine. Now, sulfasalazine in the intestines is being divided into two components. Sulfapyridine and aminosalicylate. They have different effects. Look, sulfapyridine is absorbed and has systemic adverse effects, but also systemic anti-inflammatory effects. And 5-aminosalicylic acid acts through the lumen, so locally, and has local anti-inflammatory effect. So we have systemic anti-inflammatory effect and local anti-inflammatory effect. This is what concerns to the treatment options. Now here I'd like to tell you one interesting thing. If you remember last semester we were speaking about diagnosis types in general. And I told that there is one variant for diagnosis which is called diagnosis ex juvantibus. You remember? Diagnosis ex juvantibus is also called test therapy. What is it? Sometimes in medicine we cannot tell the exact diagnosis. We are differential diagnosing. Diagnosing, at the end we have 2-3 conditions which are very similar and we cannot differentiate further. What to do? One of the variants, but it's not from the good life. We just don't have any other choice. We know that, for example, finally we have 2 conditions, either this or this. We know that there is one medication which, if this condition is beneficial, on this is not working. We start to give medication. Usually we are doing opposite. We are diagnosing, then we are giving medications. Now we are giving medications, and based on the treatment, if patient's condition is improving, we are telling that it is this one. For this, it was not working. In IBD, Crohn's disease and ulcerative colitis, this sulfasalazine, this group is more beneficial for ulcerative colitis rather than for Crohn's disease. Sometimes we may do as empiric treatment, okay? As test therapy or diagnosis ex juvantibus or juvantibus. Okay?